Hello, everyone. This is Chadi Alraies from Heart Trending. I'm really privileged today to be with Dr. Morten Böttcher. He's the recently accepted and presented science at ESC Congress 2024 in London, related to topics in coronary artery disease in outpatient setting. Morten, thanks so much for being with us and congratulations.
Thank you.
Yeah. Can you tell us a little bit about the hypothesis of the study that you presented at ESC?
So basically, what we've done in most of Scandinavia over the last couple of years is that we have changed our algorithm from using treadmill and invasive angiography to a pure cardiac CT-based algorithm. And the aim of the study was really to see whether we did, or the patients did well in this algorithm, whether we identified the ones with high risk and left the ones with low risk alone. So we looked at the prognosis, so in terms of both MACE, so a combined MACE endpoint with mortality, myocardial infarctions, strokes, and revascularizations, and we separated groups into two groups: the ones with a negative test and a positive test. And we, based on our registers, we had background population control groups, and we identified over a 2-year period. We identified more than 30,000 patients who underwent ischemia rule out, the majority with cardiac CT, but a few patients also with invasive angiography and perfusion scans. And we followed them for 12 months to look at their event rates.
That's beautiful.
And
So this is a really patient coming to the clinic, coming with some signs or symptoms of cardiac symptoms, and you chose to use CTA or non-invasive testing, but majority CTA.
yes, by far, and even since we did the trial, it has been even more pronounced now that more than 85% undergo cardiac CT. We don't do any treadmills, any tubular echo, any MR stress, nothing. If you're eligible, we do cardiac CT in the patients.
That's great.
So
Right.
we followed these two groups. So about 24,000 patients who had a normal test and about 9,000 patients who had an abnormal test. And we had a control group from the background population. So I think around more than 100,000 controls in the normal test group and 40,000 in the abnormal test group. And what we found, I think, were two things that were interesting. First of all, when we looked at mortality in the first 12 months, we did not see any signs of increased mortality in any of the groups, irrespective of having a positive or negative test. We found in patients with a positive test that they have more infarctions, more strokes, and more revascularizations, also unplanned revascularization, not just revascularizations after the ischemia test. And we found that in patients with a normal test, so a normal ischemia test, that they had no excess stroke risk, no excess MI risk, no excess mortality. They had a 1% chance of undergoing revascularization. And we thought that was really low. And as I said, no effect on mortality. So this was the first part of the investigation. And the other part of the investigation was to look at patients with a normal ischemia test to see whether they utilized the healthcare services more than the background population. So we looked at prescriptions, we looked at new diagnoses, and we looked at outpatient visits at other specialties, so urology, surgery, and so on. And what we found was that these patients who have a normal ischemia test, they utilize the healthcare system about twice as much as the background population. So they get a lot more diagnoses, they get a lot more prescriptions, and they have a lot more visits in other specialties. So our interpretation of this is that if you have somebody with an ischemia test and it's negative, you should consider other reasons for the chest pain, because very often they will have an alternative diagnosis causing the chest pain. So they are not all, just crazy and making up symptoms. So I think the two messages is that the prognosis of somebody with suspected angina is really, really good. If you have a positive test, you should be very aggressive in lowering their risk factors because they have about a 10% event rate. Mortality is not an issue, but you should really focus on these patients with a positive test and bring down their risk of stroke and MI and revascularizations. And you should be aware that patients with a negative test, they should be considered for having a different reason for the chest pain.
Just final comment, Morten, about the patient who had a positive test. Is there any way you can lower their revascularization or MI by doing an early invasive angiography?
So this is very much debated right now, how aggressive you should be. I think in general, we are somewhat conservative. We try to stick to the European guidelines. So if we have a positive CT, for example, and the patient does not have a main stem or a peripheral vessel disease, we would do a perfusion scan. We use a water pad in our area to make sure that they actually have reversible ischemia before sending them to invasive angiography. So quite few patients go directly from CT to angiography. And this has been, of course, a concern that the utilization of CT in a large scale would increase the number of invasive investigations, but we have seen exactly the opposite. It has just plummeted. The number of invasive diagnostic angios has almost disappeared.
Yeah. Well, that's really elaborate on the quote, as we say, less is more. Like by doing these tests, and you know what the patient have, you treat aggressively the risk factor, the patient will do fine. But this is phenomenal findings and definitely help this cohort of patient, which is a majority of patient comes to the clinic with these symptoms, either for screening or for atypical symptoms. But that give guidance for both the treating physician as well as reassurance for the patient that if the test is okay or some disease, there's no increase in mortality.
Not if you treat them aggressively for the risk factors and give them statins and so on. Then they seem to have a really good prognosis.
Absolutely. Morten, thank you so much for your time and congratulations again for a phenomenal study. This is very enlightening, and hopefully we can see you in the future meeting with more follow-up on the study.
We'll keep on following this cohort. So hopefully, yes. Thank you so much.
Thank you. Have a good day.